This is a model that's created for communities by communities. The partnerships you see highlighted today are the tip of the iceberg to other partnerships that also reach into the most disproportionately impacted communities. And then together, we aim to mitigate the negative impact of COVID. We're seeing it in the news today. So this need is dire today. Next slide. So these are the 6 objectives, and you hear the theme over and over today. Number 1, to identify and engage vulnerable communities. And as Dr. Lorenzo stated, this is all local, state, territories, and tribes across this nation and within those communities. The partnership model, the partners to be the face of this initiative, is the most important piece. Number 2, nurture those existing relationships and partnerships, but develop a dissemination network of information, but also activities using technology, using traditional methodologies, using community health workers to make sure that we can reach communities. Number 3, make sure that we're developing that culturally and linguistically appropriate messaging that can overcome those barriers to prevention, treatment, and also education and training when it comes to COVID-related services. Number 4, link to services, and this is where the rubber hits the road. We're trying to link our communities to services. When it comes to the vaccinations, how do we overcome the stigma and the mistrust so that people will actually participate in the vaccination, but also the vaccination trials? This considers the social determinants, which are often those barriers that inhibits, whether it's transportation, food insecurity, or other things that provide those barriers. We are to develop messaging, activities, technology that can break through, and this is done with partnership with communities. And then, of course, the research. We are a research institution. We are to monitor and evaluate everything we do. We have measures that's agreed upon with OMH, outcome measures to measure the impact of this model on the community, on COVID-19. And how do we share these best practices, not only among the partnerships, but with OMH, with the state offices of minority health, with other community-based organizations, sharing the best practices, learning, making sure it's scientific, it's measurable, but the impact is successful at the end of the activity. But another part of it is to make this model sustainable beyond COVID-19. And that is the next step of planning that we have here at NCRN. Next slide. So just to make it clear, we'll speak of some priority areas and hotspots, but as we know today, the need is all across the country, but this is a national project that will reach in all those local, state, tribal, and territories. And you'll hear from the representative of those communities today. So thank you again, and I'll turn it over to Brittany.
Thank you, Dr. Mack. Next, we'll hear from Dr. Tabia Akintobi, the Associate Dean for Community Engagement at Morehouse School of Medicine.
Thank you so much, Brittany. So I want to echo all that my colleagues have shared in terms of just the importance of your voices, your leadership, and input as we look to stand up one of the nation's largest national responses in the COVID-19 space. And so we really thank you for your partnership and anticipate all of your leadership and insights as we work collectively, and as Dr. Mack shared, in preparation for the next public health issue that we can adapt using the strategies and strengths that we learn with your engagement for NCRN. So earlier you heard the importance of engaging communities that have been disproportionately affected, which is at the core of this network. And certainly we want to stand in partnership with you as those who have established trust and relationships with communities. And certainly we want to collectively be eligible for the community's trust. And so one of the integral components at the center of NCRN is a national advisory board. And it's composed of some of the partners that you will hear about in our partner showcase this afternoon, but they represent the priority populations as well as geographies that are our gatekeepers to trusted networks that will help us to ensure that our work is community sensitive, informed, and guided. And so the NAB is designed to regularly convene to inform all of the work related to health communications messaging, as well as a dissemination of how the Partnership for NCRN is aligned with their organizations, and more importantly, is aligned with communities. So through their voices and their leadership, we want all communities and stakeholders to see NCRN as something that matters to them and where they have a voice and a place in fighting this pandemic. So the NAB will guide the development of culturally and linguistically appropriate dissemination materials. And there will also be working groups that are strategically developed based on priority population and COVID hotspots to make sure that we do what we know is true, develop responses that are not one size fits all, but really community co-created, co-tailored, and also disseminated. Next slide. So the NAB has met once, and certainly they've also been engaged in a number of the planning as well as implementation strategies for NCRN. So among those things is a thoughtfully developed survey that is designed to not just understand the gaps that exist with respect to COVID, but also to have a central repository that speaks to the existing strengths and community leadership that exists in navigating and combating the epidemic. Our approach is one that is based on resilience, obviously, and resources. And we know that a lot of the community resources that exist or that are leveraged through our national partners may not be found on a website, but represent the trust, strength, and leadership that collectively we can certainly deploy and increase awareness about to address and combat and mitigate the issues related to the pandemic. So members of the NAB will inform our mitigation strategies, and most importantly, they'll leverage their existing relationships. There is no need for us to start from scratch with partners who already are trusted leaders with networks that are nation strong. And so one of the things that will be a product of the NAB will be a national community coalition board that will really be designed to roll up their sleeves as a community majority body to be our linkages to community voice. And so you'll hear more from others specifically related to health communications, but we thought it was important to also elevate a board that would be our ear to and boots on the ground toward community engagement and voices that will make sure that NCRN continues to maintain relevance, resonance, responsiveness, and engagement with communities beyond our national bodies, but to the lay public in general. So we're super excited about all that you will inform in terms of these opportunities for community engagement and responsive strategies, and we look forward to continued collaboration with you. Thank you, Brittany.
Thank you, Dr. Akintobi. And next we'll hear from Dr. Arletha Livingston as she shares our community health worker mobilization strategy.
Good afternoon, everyone. Next slide, please. So we know that community health workers are frontline workers that are integral to any community level response. So as such, the community health worker mobilization strategy is central to our work here. So the strategy includes information gathering and planning, mobilization, and then evaluation and research. Next slide, please. So information gathering and planning has begun to identify and engage communities. We have partnered with the National Association of Community Health Workers, NACHWA, to work on the CHW mobilization response. So first, we are conducting an environmental scan. The purpose of the environmental scan is really to understand how CHWs are currently involved in COVID-19 response, where the gaps and needs are. So we are defining roles and the capacity of CHWs and CHW networks within the NCRN focus areas. We're understanding the impact of NCRN focus areas and population and how COVID has impacted those areas. And we're looking for recommendations to integrate CHWs into COVID-19 response to build trust with communities, increase access, and ensure equity within NCRN focus areas. And so we have conducted listening sessions with CHWs, CHW networks, allies, key stakeholders, and representatives from national organizations. So we've conducted 6 thus far. We began to analyze census data, social vulnerability index, county health rankings, and other data sources, and really began to synthesize the data to understand where the CHW response is now and then where it's needing to go. Next slide, please. So part of the mobilization efforts would be to hire and train community health workers. So one thing that we know is that, you know, in our response that there are never enough community health workers to go around. So part of what we would like to do and part of what we will be doing is hiring 10 to 12 community health workers from community hotspots where COVID-19 has affected the communities. And those will be hired through NACHWA. We'll begin working on that actually December and early January. So those CHWs, we will ascertain what training they've already had and then what additional training will be needed. We also will conduct capacity building with community-based organizations. So we know community-based organizations are in position to make a great impact on COVID-19 mitigation efforts. So as such, we have a Community Bridges, community health worker capacity building program for CBOs to support the mobilization of community health workers in local areas. So we'll be offering training and technical assistance. Those organizations will receive a stipend and free access to online training. In addition, our community health workers will serve on the Community Coalition Board. They will also just advise and provide feedback on NCRN and NACHWA strategies and materials. They will disseminate culturally and linguistically appropriate information, engage with other CHWs in the network, other community members and organizations in their focus areas, and also recruit community members for focus groups and surveys. Lastly, the community health workers will engage with focus groups with members of the target stakeholder community to really understand the materials and the needs of those communities. They will also participate in listening sessions with the National Coalition Board that will be conducted every 6 months. And they also will be working on the app, which will be talked about later. Next slide, please. So looking ahead, we have an information session that will be coming up Friday, December 18th. And on that information session webinar, we will discuss the environmental scan, so the results, the information from the environmental scan and those listening sessions. We'll begin to hire community health workers in December and January. And January 4th, the application portal for the Community Bridges Capacity Building Program will be open. So please join us on Friday, December 18th for more information about the CHW mobilization efforts. Thank you. Back to you, Brittany.
Thank you, Dr. Arletha Livingston. Next, I'll actually share the communications and dissemination strategy overview. Essentially, the core for dissemination and communication spans across several different elements, starting with brand management for the National COVID-19 Resiliency Network, developing key messages for strategic communications about what the network does, what our key objectives are and who our partners are that we collaborate with. It also then integrates applied health communications research, which you'll hear shortly from Dr. Holliday in regards to the formative research that we're conducting to inform our content strategy. And then ultimately, the insights that we glean from our focus groups and our interviews will also inform the digital marketing strategy that we take that is reflective of the preferences from the community. It also integrates the public and media relations elements so that we are amplifying the stories in the communities that we work with. And then also, again, as Dr. Mack mentioned, trying to integrate the outcomes that we are seeing from our efforts so that we can disseminate lessons learned and then refine the program as we go along. So next, I'll turn it over to Dr. Rhonda Holliday, and she'll speak specifically about the formative research.
Thank you, Brittany. So part of our charge is to create linguistically and culturally relevant messages and dissemination strategies. So what we have chosen to do is to focus our new messages on encouraging COVID-19 testing and COVID-19 vaccine uptake among our communities. Our partners in these efforts include ICF Next and the University of South Florida. Together, we have been engaged in a number of activities that will help inform the messages. These activities include conducting an environmental scan, where we assess what messages our partner organizations are disseminating and what messages are being disseminated to our communities. This effort has been led by ICF Next, and you will have the opportunity to learn more of the results of the environmental scan later this afternoon. Simultaneously, Morehouse School of Medicine and the University of South Florida have conducted a literature search focused on vaccination and testing among our priority communities. And the purpose of this was to identify barriers and facilitators to both testing and vaccine uptake. Some of these results will also be presented this afternoon. Finally, ICF Next will be conducting a content analysis to examine news stories that feature COVID-19. All of these activities provide background and the foundational information that will inform the development of the messages. Next slide, please. Our approach to message development will be community focused and community engaged. We have already started to engage our community partners in conversations around our upcoming formative activities. And these activities include community-based prevention marketing, which will be a strategy to build capacity among our partner organizations to engage in social marketing, key informant interviews with our partner organizations, focus groups with our community members, and neuromarketing that will be used to help test some of our message concepts. We are extremely excited to work with our partner organizations in their respective communities to create messages that are culturally and linguistically appropriate and that resonate and speak to the community. To our partners, we will continue our conversations with you to engage you and your communities in the key informant interviews and focus group process. And to our other listeners, you will get a chance to learn more about these formative activities from our partners, ICF Next and USF, later this afternoon. Thank you, Britt.
Thank you, Dr. Holliday. And next we'll hear from Dr. Ann Gagliotti, the Associate Professor of Family Medicine at Morehouse School of Medicine, as she highlights our overarching research strategy.
Thank you very much, Brittany, and it's so nice to be with all of you today. Next slide, please. I'm going to talk to you a little bit about the overarching goals and structure of the NCRN Research Core. Our main goal is to leverage the data streams and lessons learned from the network to generate evidence to mitigate the impact of COVID-19 on vulnerable communities. The Research Core has three main components. One is the rich data landscape that will be available to us through the network. The second is the research and evaluation that we will conduct using this data landscape, and then a dissemination strategy of the work that has been completed. The data landscape really is quite rich. We plan to utilize both publicly available data on COVID-19, healthcare infrastructure, social determinants of health, as well as data from the platform and from our users through KPMG, as well as other population health data from our partners at AMFAR. Additionally, we'll have rich qualitative data, as Dr. Akintobi and Dr. Holliday alluded to in their remarks, from both community partner organizations and community members themselves. We are working with Alliant, which is QIO, to really build out our data in the healthcare space from the healthcare system. Our research strategy is going to be threefold. We're interested in taking a deep dive to highlight the expertise of our key partners and the lived wisdom of our community through special population and topic briefs. We are interested in understanding what are the drivers of equity and impact of the network through our scholarly work. This is going to require data harmonization across multiple levels to leverage that rich data landscape that we have access to. And then we also have work to do understanding the implementation science and programmatic and engagement models that we will use, so we can share those and scale those models that are successful. Next slide, please. We've tried to be as inclusive as possible in our dissemination strategy. So in addition to producing peer-reviewed scholarly work, we also hope to produce relevant topic briefs and population briefs for our partners, as well as forward-facing materials for policy makers. We hope that every scholarly work or brief or policy brief will also have a community-oriented component, so that we can disseminate this work broadly across the wide group of partners that we have in the NCRN. Next slide, please. To date, we have been busy. We have been engaged in scholarly work with our research division at the National Center for Primary Care and with our partners, both locally and nationally. We've conducted multiple ecologic studies that are designed to measure equity and resilience across places. We've also looked at measures of historic structural racism on the geographic disparities in COVID-19 burden and deaths. And we've also recently had a paper accepted looking at the differences in the COVID-19 pandemic across rural versus urban spaces in the United States. Our group has also produced a detailed chart book that is approximately 350 pages, that is a detailed dive into the socio-demographic, language, healthcare, and population health landscape among both our priority populations and our priority areas or places. This includes language around sort of the built healthcare infrastructure, but also around the social needs of populations living in places and the inequities in those social determinants of health. We are working, we've worked also with our OMH partners and with our external evaluator partner, NORC, to build the data infrastructure and measurement infrastructure for the network. And we feel confident that we do have the data streams in place to measure the full impact of this program. Next slide. Looking ahead, we are looking forward to this winter conducting a data and research needs assessment with our community partners, so we can build a data sort of sharing space that's designed to meet the needs of our partners. We're also looking forward to producing a series of priority population briefs that leverages the great work that Dr. Holliday and ICF Next are doing in their formative research. And also look forward to building a communal repository of culturally and community relevant data tools for NCRN members, as there's a host of great tools available, and we hope to curate the most helpful tools for our network in a communal space. Thank you so much, Brittany.
Thank you, Dr. Gagliotti. So next we'll actually take a few moments to hear some initial questions from the audience. And so I'll turn it over to Bria to read maybe one or two questions from the chat box.
Thank you, Brittany. So one of the questions is, what states are the hotspot zones identified in?
Yes, this is this is Dominic. We're starting, and we just want to make clear we're not just limited to these areas, but the areas we identified were on the West Coast, California, in the Pacific Islands was one cluster. We were looking in El Paso, Texas, and Moore County in Texas, and that had to do with more rural areas and also the meat packing industry, and you'll hear from Nora about that today. Louisiana was an area because we were touching on the incarcerated, of course, and other disproportionately impacted community. A cluster in the Southeast with Georgia and Florida was another area, and then of course Alaska. So what we were doing with those is, and Navajo Nation. What we were doing with those areas is actually making sure that we started in the priority groups with the NIMIC initiatives. There were 5 to 6 priority groups that were named who were most disproportionately impacted. Those names will be obvious, and you'll see some of our partners on the call today. But those are the areas that we've named at the moment. But again, it's not exclusive to those areas, but that's just where we'll probably start with the community health workers and a heightened community approach.
Thank you, Dr. Mack. One last question before we move on. What has been the most receptive methods of community outreach among your partners within the Black community?
I'll take that question. I think that what we'll hear from 100 Black Men later on this afternoon in regards to some of their virtual outreach efforts, but they've also had some community-based strategies in barbershops and churches. And so I think that once we come back from the break at the beginning of the next block for the Partner Showcase, you'll be excited to hear what some of their strategies have been. Great.
Thank you, Brittany.
I think we may have time for one more question before we take just a brief break from 1:50 to 2.
Okay. This is from Mr. Fred Sandoval. He said that we have found that the Spanish-speaking written materials that are culturally developed is really helpful. We are finding that meeting with class standards helps to ensure that all partners are following that linguistic guidance. Will the NCRN use class standards to guide their entire framework?
Yeah, and I think Fred, I don't know if Fred can talk. Fred's on the phone. Of course, he's one of our partners. I don't know if he wants to expound upon that.
Fred, if you're on the line, you should be able to speak if you unmute yourself.
Well, maybe not. We can let him speak later.
Okay. Well, thank you. We'll take just a 10-minute break, and then we'll come back and get started right at 2 o'clock on the dot. Thank you, everyone.
Shops and churches from December 5th through January 30th.
I'm all in, man. Anything to help the community and our people.
100 Black men of Augusta will kick off their community COVID-19 tour right here at International Hair Care this Saturday from 9 a.m. to 3 p.m. In Augusta, Derenice Jefferson, WJBF News Channel 6.
Thank you. If we can go back to the slides and we'll close this out. I hope this makes sense. We have a saying in the 100, what they see is what they be, and we try to exemplify that every single day. And now we just have a few more slides. All right, the other thing we're doing in conjunction with Radio 1 across the entire country, Dr. Danner, I'm sure many of you know Dr. Danner. We did 2 podcasts. We're also going to be doing 4 additional town halls on StreamYard, which is a very robust media platform on YouTube, Facebook, etc., on COVID-19 topics, viral sepsis, building one's immune system, daily vitamin usage, knowing your numbers, and proper exercise. There'll be several live interviews, on-air personalities, connected TV, talking about the response, the resiliency response. Geo-targeting, which as many of you may or may not know, is specific media campaigns as it relates to COVID-19 directly to the White House, directly to facilities, NIH, etc. It's a pretty robust offering. We'll be in conjunction with this organization here. We'll be pushing out the message. Next slide. The other thing that we're pushing, as many of you know, is the immune enhancement strategy. I take my vitamins, if you guys can see this, I take my vitamins every single day, and we're trying to suggest these certain units, 50,000 units for vitamin D3, 10,000 units daily, 50,000 weekly. Zinc is another great one that, it builds our immune system. We recommend 50 milligrams or less per day. Zinc sulfide, Coley's lozenges, elderberry, etc. And obviously multivitamins every single day. And turmeric, one of my favorites, 500 to 600 milligrams daily. And I think we forget about our children sometimes, so we recommend them talking to their pediatrician to get their dosages. And then obviously with D3 and getting 20 to 30 minutes of sunshine, a lot of us as we get over 50 years old, we lose our vitamin D. So it's very important to try to augment that with some sort of sunlight. And proper exercise obviously is very, very important. I recommend 150 minutes per week. Next slide. And then to continue on to that strategy, the exercise can be broken down into steps. We're about to launch a national fitness campaign in January where we're going to have Apple involved and we're going to get the members involved to participate to make it fun. But we're really advocating 90 to 150 minutes per week and learn how to reduce your stress in a healthy way. And obviously get 6 to 8 hours of sleep per day. Next slide. Hit it again one more time. There we go. All right, perfect. So we actually had, you say, what's happening with COVID? COVID has changed our life forever. I mean, the mental stress, the suicide rate's up 30% in young men and women. So we had a mental health webinar November 18th with some esteemed panelists that went very well. And then this evening, we have an update on COVID-19 vaccines and testing and therapies with Dr. Danner and crew this evening. So we are trying to do some good stuff to try to make a difference to impact this COVID response. And I hope this was beneficial. We look forward to work with your advisory committee, and we look forward to great sessions. You guys are doing a great job, Dr. Mack. I appreciate your leadership. Thank you very much. Oh, this is a slide here that we did. I didn't know they got that in there. What we did with the virtual streams with YouTube. It just talks about the views and some of the images that it reaches. That StreamYard can use for anybody else on this line is a very robust platform. It might be the last slide. Is there another slide? Yeah, okay. Thank you very much.
Thank you, Walter. And next we'll have our presentation from Unidos US.
Hi, thanks, Brittany. This is Rita Carrion, the Vice President for Health at Unidos US. We're really excited to be part of the network and you know, with hand in hand with the leadership from Dr. Math and Dr. Daniels. So for us at Unidos US, the next slide, I just wanted to kind of give us a little grounding on who we are. We used to be called or formerly the National Council of La Raza. We're the largest Latino civil rights and advocacy organization in the country. Almost 1 in 5 Americans is Latino or Hispanics or Latinx, whichever preference you prefer, right? And 1/4 of all Americans are children are Latino. And so from California to Kansas to North Carolina, Latinos represent our future, our leaders, you know, our workers, our taxpayers. And so one of the things that we've been doing is to ensure that Latinos have, you know, equality and equal opportunity to complete college, move up the economic ladder, buy a home, and have access to health information and healthcare. And so Unidos, for the past over 5 decades, we've been working on programs, policies within our network of almost 300 community-based organizations, not only here in the United States, but also in Puerto Rico. So the next slide, if you can go to our next slide, shows a map of, you know, our Unidos US affiliate network. They are at the heart of our work. They're community-based organizations, community health centers, charter schools, community development organizations, and the like. You know, our affiliates have really been essential, you know, in really providing emergency response to the Latino community from the very beginning of the pandemic, you know, often adding new services so they can meet the mounting health, food, housing, and educational needs. And so we know that many Latinos work in essential jobs with high risk of exposure to the virus, from agricultural, grocery, and janitorial services. Many work in the hospitality sector, which has been devastated by the lockdowns or you know, all the different, you know, changes in businesses. And at the same breath, Latino students are experiencing a major disruption to their education due to the lack of access to technology necessary for distance learning and even in their own social and well-being. So underlying in our work on health is our belief that everyone deserves to have the opportunity and the ability to be healthy and to thrive. And our health is one of the most important assets and is influenced by various factors, including where we live, work, learn, and play. So I really appreciate Walter's note about taking our vitamins and making sure that we're exercising and getting enough sleep, because that's exactly what we need right now to make sure that we continue to fight for our communities, to represent our communities, to be with our communities, and for our communities to also not feel further disenfranchised or further left behind. So I think I did want to provide a little bit of just the COVID data and the Latino impact. You know, it's surpassing, you know, every day, every minute. As we know, you know, while we know that we make up about 18% of the U.S. total population, Latinos represent about 24% of COVID cases and 15% of deaths. And this is super important. And this is only just half of the information that we do have around race and ethnicity, and we don't even have the disaggregated information. So I think that's just as important element for us. We know we're walking into a number of different dark days, but we also know that there is a light at the end of the tunnel. And so, but there are some really stark realities within the data, including, you know, the result of what this toll of the pandemic has in terms of a recent study by USC and Princeton that anticipates the Latino life expectancy to drop by 3 years compared to 0.68 years for white persons. So this is an instrumental, you know, impact not only on the well-being of our communities, but really in terms of how we can be able to you know, get over a lot of the mountains and fires and be able to reimagine a better future for ourselves. So one of the things that Unidos US did really at the beginning to help mitigate the impact of COVID on our communities in April of this year, it feels like last year, right? But Unidos established an Esperanza Hope Fund to work in 3 areas. It is really to support our affiliate network, community-based organizations to respond to the needs of Latino families across the country that were exacerbated by by the pandemic. But first and foremost, we really wanted to lead a public health response, really educating our community, oftentimes in the language that they prefer to receive information, and reaching out to a number of different campaigns and information through our town halls, very similar to what 100 Black Men has been doing in a number of different areas, but really expanding the breadth, not only in how the impact has been on the health of Latinos, but also on the housing impact, economic impact, the educational impact of our communities. And at the same breath, we've been able to raise, almost $1.5 million for our affiliates to really help them support their relief and through not only keeping them, open in terms of their operations, but also having the technology so they can be able to do more. And at the same breath, we've been leading the national advocacy response, and that is so that the most vulnerable in our community are not left out of our relief efforts, and that's something that we'll continue to do on. So we're really excited to join in this partnership with the network to really try to amplify even more the next phase of what we're seeing to come, right? So one of our next focuses is really to ensure that not only our communities have the right information and the accurate information that's science-based, but also have access to critical health and social services. And through this, I mean ensuring that not only they have continued access to testing, just like Walter and the group is doing, but also in terms of them understanding about the clinical trials, recruitment of that, but then now moving into vaccine awareness and education, really improving confidence among our Latinos to be able to feel confident about the vaccine and not have hesitancy. So through this is really making sure that we're engaging in critical tables where their decisions are being made about our communities, promoting it, timely, accurate, scientific information through public health messages and awareness and educational campaigns. And also ensuring that there's an equitable and just lens in not only all the policies and procedures and distribution of the vaccine, but also on the treatment. So we're definitely at a really critical moment now that with the recent news of the vaccine and ensuring that we're all the communities, it really requires a sustained engagement and participation in our local communities. And for us, expanding where health happens really is important in terms of us seeking community leaders and community health workers and organizations as trusted messengers. So if you go to the next slide, I think has a little bit more on what I was just talking about in relation to the vaccines and trials in terms of our next phase and our focus as part of the network. On the next slide talks about, our targeted efforts under this network is really to, go to the next slide. Oh, there it is. Yeah, is really amplifying these messages, working within the network in terms of the testing, creating messages, amplifying the voice, making sure that our sub-networks, not only the health centers, but also the promotoras and the community health workers and the key ambassadors and trusted messengers have the information that they feel confident to be able to provide in the community. So a part of our collaboration, we do aim to amplify this public awareness campaigns, educational efforts, whether it looks like in terms of webinars or pláticas or chats or videos, or in terms of what is making. We've had a lot of good lessons learned over the last couple of months in terms of how best to reach our communities in different markets, as well as audiences. And when I mean not just Latino audiences, I mean, in terms of the sub-networks, those that are undocumented, those that come from mixed status families, our farm worker community, and a number of our young millennials, as well as our children. So we're looking forward to working with the network and all of you in these local efforts. So with that, on the last slide is just some existing resources that we've created. If you go to our webpage, we have a bilingual digital toolkit already in play that has graphics that you can take, and they're very simple to push out. We also have created a data dashboard that provides the latest data on COVID across a range of issues that are affecting Latinos, including projections of the virus spread. And then, our webpage that is both in English and in Spanish, as well as a number of research papers that can help serve being able to provide numbers and data and information that we can also provide and amplify with the network and all of you today. So with that, I'm going to pass it on back to Brittany for the next person.
Great, thank you so much, Rita. And next we'll hear from Sherry Daniels from Papa'ololakahi.
Velina mai kako, aloha kakayaka, winala, ahi ahi, wherever you are in the United States. Good morning, good afternoon. My name is Sherry Daniels. I'm very excited and humbled to talk story with you folks today, to share with you what's happening in our initiatives with Native Hawaiian and Pacific Islanders. Before I kind of get started, I want to be clear that Papa'ololakahi is working with Morehouse, but we actually are partnering with our Native Hawaiian and Pacific Islander Hawaii COVID-19 3R team, as well as our national partners in California and across the nation through the Pacific Islander COVID-19 response, as well as PCOPSD. So I'm going to be sharing both organizations and what we're doing kind of collectively together. So thank you again. Next slide. So when we look at our California partner, and again, I say California because that's the scope of the contract, but we actually, this group, including ourselves, reach across all states across the nation, as well down into the Pacific. So there's 9 regional teams, and you'll see that they've been doing things at the local level in the different state areas, as well as nationally. Next slide. Some of the activities they've been doing is on the state and local level, coordinating community trainings, distribution of food, as well as convening coalitions, engaging communities, participating in education campaigns, working on PSAs, especially the in-language pieces, to make sure those messages are translated into other community languages, because we know in our communities that's very necessary. Next slide. And so the other collective here in Hawaii, like I said, is the Native Hawaiian and Pacific Islander team. And we were really birthed or created out of the national response to the national. And it was really to look at how we improve the collection and reporting of accurate data for our community. It's also looking at identification and lending support to already existing initiatives that were already happening across the state. We were really thoughtful about not reinventing the wheel, and I think I heard somebody talk about that earlier, but also not about getting into spaces that really we don't belong in, that we can help support and uplift, but really understanding what our lanes are and working to uplift communities at really the community level. But also we wanted to make sure that we unified our presence, that it wasn't just a Native Hawaiian initiative, nor a Pacific Islander, that as Pacifica, we all have very similar stories and history and cultural understandings. And so how can we as a community come together to support each other and have thoughtful, sustainable decision-making? So that was really the purpose of the team. It is not easy. I think we all know that when we start engaging multiple communities, multiple personalities, it really becomes challenging at times, but really focusing on what the end mission is in how we create opportunities for our communities to thrive, not only through this, right, but as we go into recovery. So currently here in Hawaii, we have about 40 plus Native Hawaiian and Pacific Islander partners at the table, both organizations that focus and whose mission focuses on those areas, but also we have allies that engage the entire community, but also includes our NHMPI folks. Next slide. So part of our focus initially wasn't about we're going to come together and we're going to create this team. We really was thoughtful in that we have to have some core values. So in our team, we have very clear purpose, values, and our expectations of not only ourselves, but what is it that we do with our other community partners, our other Pacific Islander partners. And so this is something that we created just so that our committee members, our participants, our team, we are all moving in the same direction. Next slide. This is just kind of a visual on our number of positives. So you can see, very interesting, we are on an upswing. We probably are the state currently that has the lowest numbers, but a few months ago, we had the lowest numbers, and while the nation was kind of calming, we were surging. So we're anticipating another surge to come. Next slide. So one of the things that our group does, and also with our national, with the COVID-19 response team, is we collect data. And so really the purpose is to improve the data collection, not only in terms of COVID, but in all of our areas when we look at NHMPIs. Here in Hawaii, we actually are quite unique, where the Department of Health, with suggestion and input from the team and other Native Hawaiian organizations, was able to start disaggregating the data out for Native Hawaiians and then Pacific Islanders. We currently are trying to work with the department, our State Department of Health, to further disaggregate those subsets in the Pacific Islander numbers. So I think that's a really good thing to point, is that currently Hawaii is the only state that separates out Native Hawaiians and Pacific Islanders. Next slide. We also provide weekly updates to our communities via multiple platforms. And so this is our latest numbers when we look at that. So as you can see, they separate out Native Hawaiians from Pacific Islanders. I do want to point out, though, that you'll see on the bottom, we still have cases that do not report a race and ethnicity. So that's an issue that we want to continue to work on and address. And that has gone down, but it's still a factor. The other thing that we want to note is we started to get death data, race and ethnicity, from our state. So that's also a new kind of exciting development, in that we're able to have that data to look at. Next slide. The other thing that data and collection has done is we are looking at emerging knowledge, doing journal articles. There's actually a recent call for papers that recently closed, and we have two committees, our Data and Research Committee, as well as our policy group, that were selected for submission of full articles from their abstract. Next slide. So the other committee we have, which we recognize that COVID, that's what we're dealing with right now, but we know that recovery is on the horizon, whether it's starting to have the conversation around vaccines, but it's beyond that. It's how do we look at the economics? How do we look at the reintegration of social services and businesses and housing and all of those things that our community is going to need to do as part of recovery, as well as current. And so we are looking at creating a recovery plan as part of that committee's work, in which we are planning to share with our legislative and our policymakers, just to kind of help them lay out a pathway for that. Next slide. Again, policy is one of our biggest areas. We recognize that COVID is highly impacting our communities, but we also recognize that this is a time that we need to pivot and be very mindful of how we set it up, so that as we move forward, we don't just have a voice that's heard or a seat at the table, that we actually are able to build our table so that we can have our community's engagement and participation in the event, right? As we prepare for other things that might come our way. So policy has been an integral part in looking at issues, not just specifically COVID, but those other issues that have been impacted by COVID, or that impacts the COVID issues here in our state. So these are just some of the topics. I think people have seen on the news our travel restrictions and quarantines and all of that. So that seems to be kind of the hot topic. Next slide, please. So again, this is, we have a really great a data collective that puts out information around just the breakdown of where our funds go. So we all know all our states with the CARES dollars. What does it look like? Where does it go? How do we make better informed decisions? And so we have a data collective that puts out information all the time, just updating our communities of where the dollars go. And I think that helps us figure out where we go in terms of recovery. Next slide. You know, and I wanted to focus a lot on communication because I know that's what all of us are doing, is how do we message to our communities? And especially when for us, our communities of Native Hawaiians are spread across islands, but we're also spread across an ocean where we have Native Hawaiians that live all across the United States, all the other 49 states. And that's the same with Pacific Islanders. So how do we message that's not just culturally appropriate, linguistically appropriate, but geographically appropriate, especially when we look from our community and when we look at our culture and the culture of connection, of place-based. How do we do that when we have Pacific Islanders who live in a region that is very different from their island community? So it's those kinds of factors that really add a different layer of engagement that we have to be mindful of. And communications, we've had multiple news stories talking about our communities, how we engage them. So we've done media releases, bulletins, websites, all of those things. Next slide, please. And there's multiple threads around PRing, both with our work, but we also have like a Native Hawaiian and Pacific Islander Hui that's looking at PSAs and how we message for our communities. Here are some of our communication pieces that we've done. Like I said, PSAs, radios, social media, and as you can see, multiple language, in faces that look like them, talk like them. So it's not just putting somebody who we think might look Native Hawaiian, it's actually putting a Native Hawaiian up there, because that is what is the meat of the story, right? It's not just we're putting a picture that looks kind of like them. No, it's somebody who is. And so, you know, being mindful of the multiple languages that are out there, not in our Pacific Island communities. Next slide, please. We've also done multiple webinars, not only ourselves, but the COVID-19 National Response Team has done tons, and you'll see that sprinkled in here. They actually do a podcast called Koviki Talk, which is very, very popular. And we find that even folks down in the Pacific can call into that. We've had multiple concerts, virtual concerts, that again can be simultaneously watched down in the Pacific and across the country. And so it's provided opportunities for our communities to see, to feel, to be connected, even if they're not. And that's been the biggest challenge, is when our culture is about touch, connection, you know, sharing our breath, hugging, honies, giving lei, to now be told, put a mask 6 feet away. How do you still retain that cultural presence and cultural integrity when physically it's not possible? And so these opportunities provide that. Next slide, please. We're part of various campaigns. And if you see, you know, I talked about the concert on one side, and you can see all the countries and all the communities that represented. And it's still available on Facebook to watch. And if you have a chance, please, because you will see PSAs in languages. I mean, there was some that I've never heard spoken. And to hear it and see it was really pretty intense and amazing. We also had this Lahui Kanaka, which it was born out of the belief of discipline when we do halau, hula. And hula is just not what you see on TV. It's not the romanticized things that you watch at a luau. No, there is some protocol, there is some process culturally around it. And having that was really an opportunity for a lot of our Native Hawaiians and others really to understand the process of protocol and how we discipline ourselves and how we come together to move through this pandemic. Next slide. And then here are some of our hashtags. I'm hoping that at some point, maybe we can share this so people can click on those different PSAs and watch it. I want to show you 2 of them because I think, you know, it's pretty amazing to see something in front. And, you know, next slide, please. These PSAs, we really tried, like I said, to capture the range of our community. And so if we can share the first one, they're only 30 seconds.
Okay, great. And Sherry, I don't know if we'll have time for both because we're a little bit over time for the presentation.
So maybe we'll do the second, because
Okay.
the second actually is a joint effort with our Pacific Islander community. So I think I've talked about culture, connection to place. This is what brought us back together, that we have a shared history of navigation, of learning, of connection. And so I want to show that.
Okay, great.
Maupiaina, the greatest navigator of our time,
blessed Hawaii with the sacred knowledge of wayfinding. At a time when we were lost and couldn't see, he gave us our voyaging culture
and taught us to be proud of who we are,
to make strong, stay together,
and make one family.
His vision was for Hawaii and Micronesia to come together as one.
Today, once again, we are challenged.
It's time for us to live his legacy of one people,
one ohana,
one ba'a.
We are in this together.
So this was really done because we started to see communities start to be divisive, start to discriminate against a community that was surging in numbers. And so it was really an opportunity for our Native Hawaiian community to stop and say, we need to reset. We need to address this, and this is not how our peoples are. And so I think we've really looked at that piece. We are part of, like I said, an Indigenous Council. We're going to be participating in that. Next slide. And again, moving forward, I know we're right about COVID, the vaccines, but it's more than that. How do we set, and we've heard it in the morning talks, how do we set the way, the path forward so we're prepared, so we can address things, right? I think for us as Hawaiians and Pacific Islanders, we look back to our future and we can see the knowledge and the skill and really the history of our people. And that's what we need to look at. So thank you again, mahalo for letting me share.
Thank you so much, Sherry. And next we'll hear from the Asian and Pacific Islander American Health Forum.
Awesome, thank you so much. I just want to thank the Morehouse School of Medicine for this opportunity to share on behalf of the Health Forum's work to serve Asian American communities during this pandemic. My name is Lily Shan, and I am the program manager for the Health Forum's COVID-19 team. Next slide, please. So since the start of the pandemic in the US, the Health Forum has been at the forefront of responding to this public health crisis at the national level. The Health Forum launched 2 seminal initiatives, which continue to stand as the broadest and largest efforts of their kind. First, we've collaborated with our national CBO network to ensure that our Asian American, Native Hawaiian, and Pacific Islander communities are supported during this time. By doing so, we've created a community library with over 400 materials in 40 ANHPI and Spanish languages. This resource received over 7,000 hits and is also the largest collection of COVID in language resources that we know of. In addition, in April, we conducted an initial rapid community assessment to design the right policy recommendations and program supports to our community-based organizations on the ground. This assessment has 45 respondents from 23 states and every region of the country. Our key findings reflected a need for language-accessible COVID resources, funding for community programs and organizations, as well as benefits, food, and small business support. Next slide, please. With a partnership that has stretched for over 25 years with the CDC, whenever there's a public health response needed at the national level, the Health Forum has been that partner for AANH AMPI communities. Whether ending the HIV or AIDS epidemic, H1N1, Zika, and now COVID, the CDC has continually turned to the Health Forum to lead the AANHPI national response. Between 2 CDC COVID-19 contracts, the National AANHPI COVID-19 Health Response Partnership, led by the Health Forum, consists of 10 partners from across the country and serving the entire nation. With partners who represent a range of local, state level, and national organizations, and who work in a range of fields and disciplines, the National Partnership is the largest COVID-19 response for AANHPIs in the country. Our partners are the Asian Pacific American Labor Alliance, the Philippine Nurses Association for America Foundation, Papa'olakahi with Sherry, Association of Asian Pacific Community Health Organizations, NYU Center for the Study of Asian American Health, Pacific Islander Center of Primary Care Excellence, Coalition for Asian American Children and Families, National Council of Asian Pacific Americans, as well as the Asian Pacific Islander American Public Affairs. So the CDC partnership consists of two main areas. First, Project First Line is an IPC, or Infection Prevention and Control, education of health facility workers across the country, focusing on non-clinical food service, housekeeping, security, and reception administration, and then delivered to a linguistically accessible and culturally competent fashion. The project is a healthcare workforce IPC training initiative, and we focus on equipping our CBO partners' health workers to be active participants in IPC culture and then spread that awareness in their respective healthcare settings. The second project is called Forging Asian and Pacific Islander Community Partnerships for Rapid Response to COVID-19. It's a project that entails providing evidence-based COVID-19 health messaging to AANHPI communities that are vulnerable to COVID-19. Our mission is to disseminate culturally appropriate, multilingual, and multicultural information in a campaign for intervention on the topics of prevention, testing, access to care, and when available, a vaccination. We're using a range of data sources to identify subgroups among AANHPIs at a higher risk for infection, hospitalization, and death. Next slide, please. The Health Forum has played a major role in the legislative relief that Congress has passed to respond to COVID, including the first COVID-19 Relief Act and the House-passed HEROES Act. Our strong policy advocacy work for COVID-19 legislation resulted in COFA, Medicaid restoration being passed in the HEROES Act, and pushing for greater language access and for disaggregated data, all related to COVID-19. The Health Forum has also advocated for our enduring issues of disaggregated data collection, coverage for all residents of COVID-19 related prevention, testing, access to care, and vaccination, as well as providing resources to our communities to better respond to COVID-19. And lastly, on the regulatory side, the National Academies of Science, Engineering, and Medicine released in October 2020 the framework for equitable allocation of COVID-19 vaccine. In response to the draft of the framework in September, the Health Forum, with a total of 100 signatories, submitted a statement citing the need to include AANHPIs in addressing health inequities related to COVID-19. The final framework still remains silent on Asian Americans, despite citing all other communities of color experiencing health inequities and disparities. If you're interested in learning more, these are all on our website as well. Next slide, please. The Health Forum is also a key partner with the Morehouse School of Medicine on their two massive national initiatives. First, we're part of their national COVID-19 Resiliency Network, funded by the Federal Office of Minority Health and partnering with the CDC. We will collaborate with our AANHPI national CBO partners to disseminate culturally and linguistically appropriate COVID-19 resources. We're also part of Morehouse School of Medicine's Health Equity Tracker and sits on the Health Equity Task Force. In partnership with Google.org Fellow and CDC Foundation, as well as the Federal Office of Minority Health. The goal is to develop an open database of health equity data, as well as a website with analyses and visualizations. And then the last slide, please. Lastly, I'd like to share our work on addressing anti-Asian hate and xenophobia. First, in February 2020, we collaborated with 8 leading national racial equity anchor organizations supported by the Kellogg Foundation. These partners were the Advancement Project, Demos, Faith in Action, National Congress of American Indians, National Association for the Advancement of Colored People, National Urban League, Race Forward, and Unidos US. And second, we are currently working with the AAJC to plan and collaborate on a January 2021 an anti-Asian hate bystander training webinar series. These trainings come at a time when more than 30% of Americans have witnessed someone blaming Asian people for the coronavirus pandemic. And then the next slide, please. Thank you all for your attention, and thank you again to Dr. Mack and his team for the opportunity to speak today.
Thank you so much, Lily.
Sure.
And next we'll hear from the National Council of Urban Indian Health.
Yata, she is a poor baller Yanajia, Log Haidana and Inchla, Log Adana Abashishchin, Torch Eat Nidashiche Aro, Tunisat Nidashanella. Hi, everybody. My name is Zipporah Fuller. I am the Director of Technical Assistance at the National Council of Urban Indian Health. We are a national organization devoted to the support and development of quality, accessible, and culturally competent health services for American Indians and Alaska Natives living in urban settings. NCUI envisions a nation where comprehensive, culturally competent personal and public health services are available and accessible to American Indians and Alaska Natives living in urban communities throughout the United States. We are the only organization that represents all 41 urban Indian organizations federally funded by the Indian Health Service. On this slide, I wanted to just briefly go into how we are disproportionately affected by COVID-19. According to the CDC, American Indians are 3.5 times more likely to test positive for COVID and 4 times more likely to be hospitalized. In addition to that, American Indians are 3 times more likely to have diabetes and more than 1.5 times more likely to have been previously hospitalized for respiratory infections and diseases, and also more than 1.5 times more likely to have coronary heart disease than non-Hispanic whites. As you all know, the CDC has identified these underlying medical conditions as specific risk factors for more serious outcomes due to COVID-19. Our communities of color are being hit exponentially harder than other communities. Some of these challenges and barriers that our communities are having often stem from low-wage jobs that don't provide health insurance, paid sick leave, childcare, and other benefits that would help otherwise sick folks to take some time off to heal. In addition to that, a lot of Indian country has poor access to healthy foods. A lot of our American Indians and Alaskan Natives also reside in multi-generational households with limited space. There are also increased levels of chronic stress due to structural racism, increased incidents of violence, and everyday aggressions and trauma. In addition, social determinants of health also play a factor, which also includes lack of access to transportation, clean drinking water, and internet health access for telehealth services, which often can stem and curb infection prevention and control. One of our urban Indian organizations actually had to resort to collecting donated phones so that they were able to provide telehealth services to their patients. So in this graph, it just shows that their state rate data obtained from UCLA and Johns Hopkins as of June 5th, 2020. And what this represents is that the blue lines are states and the orange lines represent tribal nations. You will notice that the first 5 lines are tribal nations which had higher COVID positive cases than the state of New York alone. So we do have high rates of COVID-19. As of November 10th, there were at least 2,251 Indigenous Americans that have lost their lives to COVID-19. According to the APM Research Lab. This is an increase of 365 deaths compared to their report 4 weeks earlier. The true amount is not known, as we do feel this could be an undercount. This stems into the next point that I would like to make is that racial misclassification is a huge barrier for our states and communities. The mortality rate that's listed there, if you'll notice that third bullet point that states if rates were equal, and that's mortality rates. If mortality rates were equal, over 780 American Indian Alaska Native people would be alive today. That is old data. As of November 10th, 2020, if folks had died of COVID-19 if whites had died of COVID-19 at the same actual rate, about 21,200 Black, 10,000 Latino, 1,000 Indigenous, and 70 Pacific Islander Americans would still be alive. So those mortality rates do show how we are disproportionately affected. For each 100,000 Americans, about 100 Indigenous people have died from the coronavirus, which is well over the rate above any other race. As of today, the Navajo Nation also reported they have over 17,000 total positive cases in their nation alone. And racial misclassification is something that NCUI has been working on. So the racial misclassification barrier impacts funding. As you well know, it creates underfunding for our communities because we are often placed into the other category, or as you guys may have noticed more recently, the something else category. In addition, it also impacts resources, so it appears as if our needs are met when they are not, which is creating resource scarce environments, and it is creating inequity on all fronts. So we are advocating and highlighting this area of concern to Congress to ensure that American Indians are fairly represented and that our voice is heard. Next slide, please. So this was a big election year for American Indians as we broke several records this year. So if you got a chance to get to the polls and vote, good for you. We played a huge part in continuing to provide awareness and education to the public on advocacy steps. And so we also work very closely with several congressional folks as they've helped us move some big acts. This year, a record number of 6 congressional seats are currently held by Native Americans, and so we are very thankful for that. On March 6, 2020, NCRN had convened an urban Indian organization leaders call to discuss some of the needs in preparing for responding to the COVID-19 pandemic. So that helped us identify the current needs at that time. That included PPE, telework support, telehealth capacity, system upgrades, and additional items that had been needing attention or fixes. Future needs that our UIOs are telling us include testing supplies, staff capacity, additional infrastructure needs, vaccine support, and also focusing on future chronic illnesses that may be exacerbated due to COVID-19. In addition to our response, we advocated to Congress using letters and written communications. On February 28, 2020, NCRN had sent a letter to the Appropriations Committee requesting $94 million for UIOs and emergency funding. This is a continuous process, and NCRN does continue to advocate for funding to get to Indian country. In March, NCRN sent letters to Congress, and we targeted congressional leadership, the Appropriations Committee, and Native American Caucus. In addition, we also used coalitions such as NCRN. It was very important as other Native American organizations joined with us, such as the National Council of American Indians, the National Indian Health Board, and our team came together to join advocacy efforts to move the congressional needle. We also wanted to ensure that we reminded the federal government of their trust and treaty responsibilities they have to Indian country. In addition to that, we also advocated to federal agencies. On March 10th, NCRN had sent a letter to Secretary Azar requesting that 120 million people go to Indian healthcare providers. Of the $40 million set aside in the first COVID-19 package, letters to the White House were also sent. We also facilitated stakeholder opportunities. So we had our urban Indian organizations dialogue with federal agencies. We had the IHS host weekly calls. We also hosted listening sessions with FEMA and the CDC and IHS. We also participated in federal agency convenings. More of note, we did impact 4 bills that were passed, which provided COVID-19 relief to Indian country. The last time that Congress enacted broad-scale relief for Indian country was in March 2020. Congress is currently debating long overdue COVID-19 relief funding in which NCRN is actively engaged in to ensure that resources continue to be allocated to Indian country. Next slide, please. We did release a coronavirus resource center that was launched in March and is accessible on our website and is available to everyone. It was being updated daily for the first 3 months, and now it is updated weekly with new resources. We have over 100 resources for our American Indians and Alaska Natives on COVID-19. We also do have 2,700 page views since the launch. NCRN also hosted bi-weekly communities of learning focused on the COVID-19 response, which also included videos, tools, and workflows, such as drive-through testing sites and best practices sharing for our UIOs. In addition to these initiatives, we are also part of CDC's Project First Line and are actively recruiting 5 urban Indian organizations that will lead the way on providing feedback and also information to the CDC as it pertains to the American Indian Alaska Native population. We are also looking to host a Project Echo for these champions so that they are able to mimic and house additional topics such as Hep C, HIV, and other initiatives within our team. Next slide, please. So what's ahead for us is addressing the ongoing mental and behavioral health impacts related to the pandemic. We're now moving into focusing on how adults and youth are addressing isolation, loss, suicidality, alcohol and substance abuse, and domestic violence, which has also been exacerbated since COVID-19. In addition, we're also working on including traditional activities that allow participants to join us for therapy through art. We're also addressing increases in homelessness and housing insecurity, job loss, and hunger. As mentioned, we do have various communities of learning topics, and these are just the few topics that are upcoming. Future topics will include COVID-19 sessions, as well as accreditation sessions that focus on enhancing the quality care that our Indian country health centers provide. We'll also be focused on the vaccine distribution to ensure that American Indian clinics and facilities are not left out. We have been working closely with the current administration and Congress to ensure fair distribution for Indian country. One of the highlights we do have, if you are interested, is we just kicked off a virtual powwow on Monday. It was an hour-long celebration to close out Native American Heritage Month, which, as you know, is in November. We encourage our audience to start their week reconnecting to the culture through prayer, song, and dance. Our MC educated audience members on the types of dance, history, and how culture is medicine and is a part of health and healing. Nakui is focused on bringing people together to create a collaborative movement to create resilient communities. We come from a long line of storytellers, farmers, singers, and healers. We are people raised on using past traditions to give us strength, hope, and healing during times of tribulation and heartbreak. It is these same tools that we draw on today and hope to share with others as we will get through this pandemic. We look forward to partnering with everyone on this panel and our communities across the nation as we move toward action and continued advocacy. We wanted to leave you with a quick 30-second video and to give you guys a reason for your hearts to smile today. And if you want it to, yep, perfect. Thank you guys so much.
Thank you, Zafora. And next we'll hear from the Association of University Centers on Disabilities.
Hi, everyone. My name is Denise Roselle. I am the Director of, thank you, I'm the Director of Public Policy for the Association of University Centers on Disabilities. I wanted to start out by talking for a minute about who AUCD is. We are a member organization that supports and promotes a national network across the United States and every state and territory of university-based interdisciplinary programs that serve as a bridge between the university and the community, particularly around issues of disability. Originally around issues affecting people with developmental disabilities, now more generally around connection with people with disabilities. And specifically, we're made up of three kind of sub-parts, if you will. The 67 University Centers of Excellence in Developmental Disabilities. These centers are all based at universities, some in medical schools, and participate actively in their communities, trying to help the community and people with disabilities in that community to promote independence and productivity and community inclusion for people with disabilities. We also have our LEND programs, the Leadership Education in Neurodevelopmental Disabilities. LEND is an interdisciplinary leadership training program for young professionals in the field. And when I say the field, I mean the field very generally and broadly in terms of disability services. So that's everyone from your pediatric, your developmental pediatrician to occupational therapists and physical therapists to other kinds of service providers and professionals, but it also includes parents, for instance. There's a parent faculty person involved in all of these LENDs. There are self-advocates who are also LEND participants who go through this training along with the professionals in the field. So there's a broad experience for everyone about what is disability and what is disability about. And then lastly, there are 14 intellectual and developmental disabilities research centers, the IDDRCs. These are the true research folks. They're doing the bench research on cause and effect, all the things you think of traditionally as bench research. So let me go to the next slide, please. I thought it would be useful to talk a little bit because disability is an overarching theme across all of the communities that we're talking about. The COVID-19 pandemic has disproportionately impacted the health and daily lives of individuals with disabilities. WHO and CDC both have articulated the increased risk for people with disabilities, and that's not just based on what we traditionally think of as the comorbidities that you hear about for COVID. It's a much broader conversation about disability. There are even a couple of studies that have been published recently. The links to all of these are here. I'm hoping at some point that you can get that information, but a lot of this stuff is also linked on our website, so I can drop that into the chat too. We're seeing studies come out now. For instance, there's a new one that is referenced here about the increased mortality risk for individuals with Down syndrome from COVID-19. Part of that may be tied to some of the comorbidities, but not necessarily. And then we're also seeing heightened risk for people with developmental disability, other types of developmental disabilities, in addition to intellectual disabilities and Down syndrome. So I want to make sure you understand that in the context of disability in general, but then layered on top of all of the things everyone else has been talking about here about the risks in racial and ethnic communities and the targeted communities that this project is working with. So layer on top of that the disability risk. For instance, 1 in 5, it's 1 in 3 in 10 of American Indian and Native Americans have a disability. So think about that layered on top, and all the other data layered on top with the disability issues. And some of those disability issues are going to be the same across communities, but as you all know, communities differ. It's all about what's going on in the community as to how people respond to that. Well, that's true in disability as well, both across the racial and ethnic community, but also across the disability community. So part of our job from AUCD in this partnership is to help bring some of that experience. Next slide, please. I talked briefly about intersectionality, but so the issues that the disability community writ large are looking at in this world of COVID. One I talked about a minute ago is intersectionality. People do not understand out there in the great world, do not understand that obviously you can have both. You'd think it would be obvious. You could be someone who is African American and has a disability, and you are part of both of those communities. And for some reason that isn't considered as greatly as I wish it was. But that's one of the things that we have been raising to the top to say, this is really important and you need to pay attention to this. Another one has to do with vaccine distribution. I know we're all looking at vaccine distribution. We have been looking specifically at a couple of things. One, so, individuals with underlying conditions. But as I said, underlying conditions is often defined very specifically to a very specific of like 5 conditions. Well, the disability community writ large is much bigger than that. And the risks that go with people with disabilities is also much larger than that. And as I say, the Down syndrome, some of the research is showing that now. Vaccine distribution, also the issues around individuals living in long-term care facilities. So often what we talk about is people over a certain age living in nursing homes. Maybe you talk about folks who are incarcerated, who also have a large percentage of whom are people with disabilities. But those people living, also that should include at least, and this is part of the issue that we're facing, should also include people who are living in other kinds of congregate settings, whether that's group homes, whether that's mental health facilities, all kinds of different congregate settings, and it should be that broad. And then accessibility of vaccine distribution. That's everything from, is the location accessible? Do you have an ASL sign language interpreter for people who need that? Have you thought about people who, for whom medical, and that's down a little bit further on vaccine hesitancy, in the disability community, as within many of the other communities we've talked about, there is a great hesitancy to trust the medical community based on past experiences. The medical model has not necessarily done well historically for people with disabilities. And so there is a great hesitancy to trust that, and to trust being able to be about and to be included and to have our needs met in that situation. Another issue we've been looking at is disability service providers, and I want to raise that here for sure. These are generally paid, like personal attendants, caregivers, people who work with people with disabilities to support them so that those people can be in their communities, can go to work, can get on the metro, can be in the community, can go to church, can do whatever those things are that make for community inclusion. Well, a great proportion of disability service providers are from the very targeted communities that we're talking about. They are people who have gone in and day out and interacted with folks with disabilities and continue to do so, but have not had sufficient PPE, have not been included sufficiently in the testing, have not been included in some of the vaccine priorities. All of that these are issues that we're raising. And then understanding the information being provided. So, is the information we're providing to people in plain language so that it can be understood and everyone knows what we're talking about? And generally speaking, when you say plain language or easy read, lots of people, again, think about that as just accessible for people with intellectual disabilities. No, what we are finding is that if you put something in plain language, it helps everybody understand it. It helps Joe on the corner, it helps the person, the pharmacist, it helps the person who works in the grocery store, everyone. So making sure, part of our goal is making sure that the materials that are going out from this project, as well as from AUCD and the work that we're doing, are in plain language. And then there are other accessibility issues involved there too, whether it's screen reader accessible for folks who are blind or have visual impairments, whether it's sign language, or captioning, or all of those issues. And I also want to hit on civil rights for a minute. There have been some significant civil rights issues around COVID for the disability community, just as there have been for the other communities we've talked about. The disability community in particular has faced issues of rationing of care, where basically stereotypical decisions and assumptions about quality of life are being made such that, this person with this disability does not deserve or is not entitled to a vaccine at the same level, or to care, or to the ventilator. And we've seen people dying. There was a case in Texas, there have been several others, where judgments were made based on that person's quality of life because of a disability, without at all talking to the person involved. So that's another piece of it. And then hospital visitation, there have been some significant civil rights issues around that as well. And if someone needs a communication, someone to help them with communications, or uses a variety of communication supports, those supports need to be allowed with them in the hospital, as well as in the same way they get them in the community. So, the ADA applies now in life of COVID, the same as it applied before. So those are the issues that are being faced. Let me tell you a little bit about what we've been doing. Next slide. I want to make sure I'm watching my time. Yep. Next slide. So activities within the AUCD network that we talked about, we've done regular weekly and now bi-weekly calls. There's a lot of advocacy. Lots of you have talked about what you've been doing with Congress. We have been doing the same. Lots of state advocacy as well. We do a disability policy news every week, which has a description of what we're doing, as well as a plain language description of it. We had a campaign called What We Need that had over 60 social stories and blogs and short videos from people with disabilities saying, this is what we need. In a time of COVID, this is what we need. I heard somebody, whoever it was that was speaking earlier, about having actual people with actual, who are actually native, or it was Hawaiians, that's who it was, saying real people doing that, that's what this was about. We've done webinars. USETs from around the country have also done all kinds of materials, both in plain language for caregivers, people with disabilities, diagnosticians, all kinds of people. Next slide. And those actual materials, we have over 700 pieces of 700 resources in a Dropbox that we have built for our network. And that's the link for that. And then recently, the three things that we've done just most recently have to do with money flowing into states and the questions of how to influence what's going on in your states and in your communities, particularly the new one around vaccine distribution, I think is really important. How do you find your state plan? How do you look at your state plan? What questions should you be asking? Who's left out from the disability community? How is it going to happen? Have you thought about access? All of those same questions, so that people from the USAID network can go in and say, here's what we're doing, here's what you're saying, here's what you should be saying. How do we influence that? So that's another important one. Again, these are links. So if you go onto our website, which I will drop in the chat, but it's aucd.org, and search for the documents, they're all on our website. The last thing I want to say in moving forward with this, first is to thank the folks from Morehouse. Unlike some of you, some of the partners, we have not worked with a lot of these partners before, and we are really excited to be here and to be able to talk intersectionality with all of you about your expertise and bringing together some of our expertise. So we are thankful to Dr. Mack and this project and the Office of Minority Health just to be here. This is a good connection that I think will yield lots of important things in communities. And that leads me to the last thing I want to share, and that's that one of the things in the disability community that is absolutely non-negotiable, quite frankly, is a saying that folks, particularly self-advocates, use that says, nothing about us without us. And that's what I see this being all about. It's like by communities for communities. Well, from the disability community point of view, it's nothing about us without us. So thank you. I'll drop my email for any other contacts, and I'll drop the AUCD website into the chat. Culture is medicine. I love that. I'm looking at the chat. See, I think every community has something like that saying. So from our point of view, nothing about us without us, and we are here to make sure we are all at the table. Thank you.
Thank you so much, Denise. So next we'll hear from the Dream Corps Cut 50 program.
Hello, I'll start with, of course, an introduction of myself. Hope everyone is having a good afternoon, and very happy to be here. And I send greetings from the Dream Cut 50 and the entire Dream Corps as well. My name is Tina Baker. Sorry, I have a dog in the background. Sorry about that. My name is Tina Baker. I am the senior organizer at Cut 50. My job primarily is to manage our field people, our organizers out in the field. But I'll start with like a brief introduction of what Cut 50 is before I get into our empathy network. Cut 50 is an initiative of CNN commentator Van Jones, as well as Jessica Jackson, who is an attorney and advocate for criminal justice reform. We are one of 3 initiatives founded by Van Jones. The other 2 are Dream Corps Green for All, which focuses on climate justice initiatives. And we have Dream Corps Tech, which focuses on tech policies, specifically like artificial intelligence in the law enforcement context and anything that kind of violates privacy. And it also opens opportunities for people that are formerly incarcerated a chance to like work in the tech industry. So we have like a cohort that does like coding and they end up getting jobs. It's a phenomenal program. But yeah, so Cut 50 is the 3rd initiative of Dream Corps. And our role is we focus on criminal justice reform policy. We are the winningest criminal justice reform organization in recent history, having passed most recently the First Step Act about 2 years ago. It was signed by President Trump. It was a huge bipartisan effort. And while we were excited and happy to have passed that law, that policy, we know that it is just like its name, it's a first step. So we are very excited to work with the Biden administration to see what other substantial reforms we can do. Another thing that we do under Cut 50 is our empathy network. The empathy network, you can go to the next slide. So I don't want to talk. Okay, so the empathy network So we started that, our first one, our first day of empathy under the Empathy Network in 2017. So just a brief history, the Empathy Network is about 3,000 or so organizers, and they have three classifications: lead organizers, supporting organizers, as well as ambassadors. Our lead organizers are typically like your policy heads. They understand policy, they know how to advocate in state legislatures across the country, and we use them to basically tell this, like, get across the policy that we're hoping to enact or help them with their policy. The supporting organizers are not necessarily keen on policy, but they are great at event planning and logistics, so they help our lead organizers. And then the ambassadors are those that are directly impacted by the criminal justice system. So to be people who have served time, or family members or loved ones who've of people who are currently in prison, and even felony disenfranchised folks. And those are people who, you know, pled guilty to a felony but didn't serve jail time. But we had our first day of empathy in 2017, and that is a day where we bring together all across the country our lead organizers and other volunteers in events to basically put a face to the criminal justice system. Cut 50 has been so successful because we basically, of our network and what we do, we get policy done through humanization. We tell stories. So as to date, the First Step Act has released about 15,000 people from federal prison. In addition to that, we've had our volunteers across the country in 30 states passed what we call dignity bills for women. I don't know if any of you all are aware what women experience while incarcerated. They are shackled to beds during childbirth, which is very traumatic. We've had women give birth in prison and did not get adequate care and have lost babies. So we've legislated against that, as well as women who are forced to change or shower in areas where there are male guards. And we also, part of the Dignity Act or bills are to basically provide products for women when they are going through their monthlies, because they typically are required to purchase those. And if you know anything about women in prison, sometimes you don't have the money. And a lot of women aren't able to take care of themselves during their monthly cycles. And that is in itself both traumatic and embarrassing. So that's a little bit about what we do. And the Day of Empathy is our showcase event. It is every March, the first Tuesday every March. So we are in planning mode right now for that. And what we do with the Day of Empathy is we continue to build out and coordinate our ever-expanding empathy network, composed of partners in all 50 states, in Washington, D.C. and Canada. The grassroots organizations that are a part of Cut 50 are primarily led by people who've been directly impacted by the justice system. And there are what we call our empathy ambassadors, like I mentioned. The Empathy Network partners, they are at the forefront of all our campaigns, ensuring that those most impacted by the justice system have a seat at the table. Because that's what we find a lot of times at Cut 50. We are so focused in getting people that have been incarcerated a seat at the table. Our National Director of Organizing and Partnerships, Lewis Reed, who sends his regards, actually served 14 and a half years in federal prison. And we are so focused on giving those people who are, you know, close to the problem and understand the problems a seat at the table to be able to come up with viable solutions. Okay, next slide. So how we do what we do, we have people, power, and policy. So people are our most important. We have an extensive personal relationships. We research and we have like a referral network that we have. We identify and support organizations and organizers that are dedicated to uplifting the leadership of people directly impacted by the justice system. So we have a lot of people that, like I mentioned earlier, they have their own organizations within their local communities who come to us and say, hey, we need help getting this bill passed, or I have someone who is in prison and we need help, you know, seeing what our options are. So those are the kind of services that we can refer them to people, or we can help them draft policy. And then under power, we invest in our partners with funding, communication support, advocacy training, toolkits, and collateral. And these resources help unite groups under a singular banner with shared messaging and goals. So right now, we're getting ready to plan our Day of Empathy. So our lead organizers, supporting organizers, and ambassadors will be going through an amazing training with on legislative advocacy, digital organizing, how to tell a story, because like I said, that's how we get our work done, through storytelling. And they're preparing to go through that in January. And under policy, we have an amazing policy team where they draft policy. So if you are a partner organization of ours, and let's say there's a bill in your state that you're wanting to work with a congressman or, a local state legislative member on, we will be able to help you and kind of advise you on what to do, because that's what we're about. We are about passing equitable criminal justice reform on both the federal and the state level. Okay, next, yeah. So the Day of Empathy, like I mentioned, it is just one day, but it isn't just a single day of action. It is a celebration of our year-round efforts to build capacity among under-resourced but highly leveraged groups that make up the Empathy Network. So throughout the year, we provide communication support, advocacy training, introductions to lawmakers, policy development, and connections to influencers, and support from national partners, as well as content and messaging. So what that means is we basically have the event done for our lead organizers and ambassadors. We provide them with everything that they need, from the training to influencers. We had Kim Kardashian, who is one of our influencers and partners with us. We also work with Common and John Legend as well. There are a number of influencers that will join us either for the Day of Empathy or throughout the year for events that we might have. But leading up to the Day of Empathy, as I mentioned, we do host a series of webinars and conference calls to stay closely connected to our partners and provide support. And in 2019, we launched an official empathy platform. So the Empathy Network has a digital community to share their challenges and work ideas and solutions. So that it's a Slack channel where we have hundreds and hundreds of activists and people who run community-based organization focusing on criminal justice reform. They are in the group. They're constantly working and throwing out ideas and job postings and whatever else they see fit to post in that group. Next slide. So we are planning, as I mentioned, for our 2020 Day of Empathy. Over the last 3 years, though, we have worked to scale the Day of Empathy to reach all 50 states and Washington, D.C., and we are hoping to do that this year. And we needed to tap into a nationwide community of directly impacted advocates. Last year, we achieved that goal, and in the 4th year, the Empathy Network is now 3,000 members deep, with membership spanning all over the country. We also have about almost 300 partnership organizations. So these are actual organizations that work with us on various things, and we provide support to them as well. Despite the circumstances surrounding the outbreak of COVID-19, our team made the difficult but necessary decision to move our National Day of Empathy from in-person convenings to a digital day of action. So we had events in North Carolina, Georgia, California, Pennsylvania, in a number of states that were online, and they were advocacy events where people were able to speak with their local representatives. And this is just a slide of our influencer support, legislator and influencer support. Joanna McClinton, she is, I believe she's in Pennsylvania, Congresswoman there, who tweets about our Day of Empathy and tags Van Jones and Cut 50, as well as I mentioned Kim Kardashian, who is actually studying she's taking her bar exam preparation for the California State Bar under our organization. So she's an amazing person and an advocate and supporter of Cut 50. Next slide. Okay, so the Cut 50 team co-founders, as I mentioned, Van Jones, you can see in the picture in the top center, and right under Van Jones is Jessica Jackson. She's a co-founder. And then under Jessica to the right is Matt Haney. He is another co-founder of Cut 50. They joined Martin Luther King III, which is of course Martin Luther King's son, for our 4th annual Day of Empathy, which was digital. And even in the midst of, turbulent times, we continue to fight for dignity, justice, and freedom to our community members who need it most. And the young man to the left, Tony Lewis, he posted a 4 p.m. count. If any of you know of anything about people that are incarcerated, there's always a 4 p.m. count to make sure that they keep track of all the people that are in prison. So he did a 4 p.m. count. It was symbolic to bring awareness, solidarity to the men and women being counted at 4 p.m. daily in prisons. And Tony himself, it was a recipient of his freedom under the First Step Act. I believe he served about 20 years in federal prison and was able to come home after the First Step Act was passed. Immediately once it was passed, a few thousand people came home as a result. Next slide.
And Tina, we do have to be mindful of the time. We kind of over time about 15 minutes, and so just wanted to remind you that.
Okay, yeah, that's fine. That we can breeze through it. I have a meeting after this too. You can go past that one. So this is just a figure of what we do. 239 million impressions from the Day of Empathy. Next slide. Moving forward, looking beyond the pandemic, we will continue to take action with other organizations to ensure the appropriate responses are taken against the coronavirus. We are engaging in federal and state policies. We're hosting COVID-19 dispatches and ensuring that jails and prisons are prepared for a potential outbreak and rapid responses. We promote and distribute COVID-19 materials to jails and prison, which is what we are going to be doing with you all. We have a network of about 500 people in prison currently that we have access to. We do have relationships also with commissioners and wardens across the country. And that's all I have. Any questions?
We're going to hold the questions for the next Q&A session, but I think that we can go ahead and move on to Nora Hernandez from the University of Texas at El Paso. Thank you, Tina.
Good afternoon, everyone. Muy buenas tardes a todos. My name is Nora Hernandez, and I am with the University of Texas at El Paso. We are situated in the binational tri-state region known as the Paso del Norte region, in which Texas meets New Mexico, and we border the state of Chihuahua, Mexico. Next slide, please. So recognizing that COVID-19 has disproportionately impacted communities of color and certain populations, our efforts entail engaging with migrant workers, that is farm workers, dairy workers, and meatpacking workers of rural communities in El Paso and Moore, Texas counties and South Doña Ana, New Mexico County to disseminate culturally and linguistically appropriate information on COVID-19. Next slide. This map provides perspective of the areas that we are covering. On the left circle, you will find Doña Ana. At the center is El Paso County, and on the top right, Panhandle area of Texas is Moore County. As you may have seen in the news, meatpacking plants in Moore County and Doña Ana have had COVID-19 outbreaks that have forced these plants to shut down for periods of time. As you may also have seen in the national news, El Paso has been severely impacted by COVID-19 with a surge in cases. In less than 3 weeks, a 300% increase in hospitalizations, and we are now close to 1,000 deaths attributed to the virus. Next slide, please. So as part of our effort, we are utilizing community health workers or promotoras to assist us with message distribution to our target population. As Dr. Livingston noted earlier, community health workers or CHWs are highly respected. They're frontline public health workers who are trusted and have a close understanding of the communities that we are targeting. We are training them on the physical and mental effects of COVID-19. We're also letting them know the resources that are available in their respective communities and ensuring that they're prepared to provide the education that's needed to these communities. They're also assisting us in tracking and ensuring that we are evaluating our efforts. And you can see some of the images of our promotoras that are assisting us in our project. Next slide, please. So for this first year, we have divided the project into 2 phases. In phase 1, we are providing COVID-19 information regarding flu vaccines and where to obtain them, testing sites, and health and social services pertaining to each of our communities. For phase 2, we'll be focusing on educating regarding COVID-19 vaccinations. Next slide, please. And so as part of phase 1, we partnered with a local foundation, the Paso del Norte Health Foundation, that in October, they conducted community-based focus groups in our predominantly Hispanic Latino community and incorporated promotora input to develop messaging. And so some of the findings from this formative process included the following. There were moderate levels of perceived risk, accurate perceived benefits of practicing preventive behaviors, but there was also mistrust of national and local government messaging. And so therefore the 3 topics that are part of our print collateral that were developed include mask wearing and the proper use, mass gatherings with the holidays around the corner, ensuring that there were some preventive measures, and civic responsibility. So what to do if you test positive for COVID-19. Information is available in English and Spanish. And as Sherry Daniels mentioned earlier, we wanted to utilize people that were in fact workers and are part of our communities. We are also utilizing the NCRN logo and promoting the website and galvanizing our community organizations, our community partners to engage on the NCRN's Twitter and Facebook pages. Next slide, please. And so all our efforts are team-driven, and I would like to acknowledge first the internal team at UTEP for their direction and support. Next, the community organizations we are partnering in order to assist us with the promotora recruitment. And then lastly, the team that has been receptive to us utilizing the messaging. We have collective messaging from different multi-sector organizations, and we strongly believe that this will strengthen our message and promote trust. We are so excited to be part of this National COVID-19 Resiliency Network and contributing to this important work. A round of applause to all of the partners that have been part of this showcase. Thank you so much. Muchas gracias.
Thank you, Nora. And so now we'll go ahead and move into the next component of the webinar today. We'll skip the Q&A session, but please do include your questions in the chat box so that we can send written responses to you after. I'll go ahead and turn it over to KPMG with Todd Ellis.
Yes, hey Brittany, can you hear me okay?
Yes, we can hear you great.
Great, I'm gonna be very cognizant of time to ensure that we do leave some time for Q&A. But first, I would like to tell everybody I was really impressed with all of the great information from all of these very valuable community-based organizations, and actually look forward to the continued partnership, because based on what I heard today and going into this very unique project or program at a national level, our platform that we're building is only going to be successful as our ability to partner with the community-based organizations. So thank you. Thank you to Dr. Mack. Thank you to Dr. Montgomery Rice for this opportunity. So let me go ahead and get started. So I'm gonna show you just one journey as we talk about the platform that we're developing. It's a platform that's built on Salesforce with regards to how we're gonna do some outreach to these populations who need this information the most so that they do have the right access to resources, whether that's mental health, whether that's food, whether that's vaccines, whether that's testing. That's the purpose of this platform, to disseminate the right information at the right time to the right population. And we know going into this that technology is not going to be the answer for everything. We're going to have to continue to work and be very agile when it comes to how we engage with our community-based organizations, how we engage with the various populations. Also, we're going to continue to work with the CBOs, Morehouse, et cetera, because we're creating an agile platform, meaning that, you know, one approach may not be beneficial for everybody. So we're creating an agile platform where we can actually change and develop the platform to be meaningful, you know, kind of every step of the way here going forward. And again, I do want to reiterate, CBOs are so important that we got to be in constant alignment with the CBOs with regards to all of the great things that they're doing, but more importantly, making sure at a national level that these populations that we're serving, they understand what's out there from a community-based organization. That's going to be key. Next slide, please. So this is kind of the timeline of the platform, and I'm happy to report the platform is live right now. So if you were to go out there, you would actually be able to go to the website and actually register. So if I'm a citizen, African-American male, I can actually go ahead and register in the platform today so that they have the information and you can actually, you know, get alerts. And as we start to roll out more functionality, you're going to get alerted. So who's ever registered, you're going to get alerted. Secondly, we know that some individuals, technology can be a hurdle. So by the end of this year, calendar year, there would be a contact center. So if you're accessing the website and you're having some issues, there is a 1-800 number. And I think that's so important because we want to make sure we engage and that individuals do not get frustrated with the use of technology. Around late January, early February, we're going to really have some pretty amazing technology when it comes to if I'm an African-American male in Atlanta, Georgia, and I type in my zip code, I will actually be able to see what services are around me. That could be scheduling a testing at CVS, getting a vaccine scheduled at Walgreens or Walmart. I'll be able to understand where I can go within a certain mile radius to get food or mental health type of services. So that's just some of the functionality that's going to be available to the citizens that we are serving. Next slide. All right, so now I'm going to take you through a quick journey. This is just one journey of somebody actually using the platform. Now, again, this functionality is going to be available around the end of January, early February. We're still developing some of this with Morehouse School of Medicine, but more importantly, with some of the feedback that we're getting from the CBOs and the various stakeholders that are a part of this unique program. So if you look to the right, you're going to see that we have this platform loaded with different languages. That's so important. Right now we have 11 languages. We're going to bump that up to 30 and possibly even more because, again, we know if I'm a Pacific Islander or living in Hawaii and I'm engaging in this platform, but I can't understand it from a language barrier, I'm never going to come back to the platform. But we knew that, and at any given point in time, you would be able to go click on your particular language that you want to see this in, and the website will change to that specific language. So we think that's a huge benefit. So this is the landing page that you will come to where you will log in. If you wanted to contact somebody at the call center, you would use this platform. But more importantly, you can see at the bottom, it also gives you access to various different resources. Next slide. So again, I am a user. And this, I think this is what's really important. One of the key aspects of this. Again, I'm using this platform and I'm going to put in my zip code. Based on my zip code, I'm going to be able to get very unique information For an example, I would be able to go in and put in my symptoms. I can even go in and understand what's the risk factor for me in my particular county in Atlanta, Georgia. So that's some of the information that's going to be made available to me. So if I were to click on what's my risk area, would you go to the next slide, please, Brittany? Here we go. So you would get this presented to you. Now, one other thing, you will look to the left. There's a menu bar where you could get information with regards to testing. We know in certain populations, they're having issues with clinical trials. So you could have the functionality added to understand where these particular services are with regards to where you are from a geography perspective. So again, I would be able to actually say, I'm in Georgia, tell me, or in Atlanta, Georgia, tell me how close the next CVS is so I can go schedule a test, or Walgreens to get the vaccine, or if I'm in search of food, where can I go? This platform will give you the actual ability to do that, schedule yourself, but more importantly, if you look at the bottom, it's actually going to show you in your particular area the COVID risk kind of factor, if it's high, if it's low. But also what's unique as we start rolling out vaccines, you will be able to see, how vaccines are having an impact in your particular area. And this is made available through a signals repository where we're collecting 65,000 data elements that's given us the social determinants of health that we're getting from, the CDC, local health departments, hospitals. We're using all of that information to present a picture to the citizen who's using this so they can understand what's going on in their area, but more importantly, where can they find resources to help them at that given point in time. Another key aspect of the data that we're collecting, this data is collected daily and weekly, so it's always being refreshed. So you'll be able to look at this as a citizen and really understand what's going on in a very dynamic fashion. This platform can be used via mobile, also a desktop. So again, we wanted to make it portable. So again, you can use this anywhere you go at any given point in the nation. You're going to have access to this type of data. Next slide. And lastly, these are some of the views that are very important to Morehouse School of Medicine, but also the CBOs. So now this is something that Dr. Mack or Dr. Montgomery Rice may look at and say, how are we doing? How are the CBOs doing? But more importantly, as we start aggregating the data, we can find gaps that say, okay, in this particular geography, they do not have a program to get food to these populations. They don't have a program where they can go within a 5-mile radius and get COVID testing or vaccines made available to them. So these type of reports will allow us to understand as community-based organizations and as researchers to really understand where the gaps are, where do we need to fill the gaps, where we're doing good, where we may need to improve upon. So we're going to have many different views that one can look at to really understand what is that data telling us about the populations that we're serving, how do we close those gaps, and more importantly, how do we curb health inequities. So Brittany, I think that was all for today. I tried to keep it short. I wanted to respect the time for Q&A, so I will hand it back over to you and I say thank you.
Thank you so much, Todd. Alrighty, now we'll hear from the University of South Florida as they talk about our formative research insights.
Hi there, everybody. It's a pleasure to be here and listening to all the fantastic work that everybody's doing. I think that it's not going to be only us at the University of South Florida, Florida Prevention Research Center speaking with you this afternoon. It will also be Robina from Josiah Willock from Morehouse. So we'll be sharing in this presentation. Next slide, please. So what we're going to be discussing with you is some of the scientific background that goes into developing the communication messages together with you. And part of what we needed to do was the first step was to conduct a literature review. And when we say a literature review, it's looking at what has been published in the scientific journals, not necessarily what's been out in newspapers or other sources, which comes up in the environmental scan. So we had 2 questions that we were asked to research from the scientific literature, and these were, what do we know that would pertain to COVID-19 screening or testing, and what do we know that would pertain to the potential acceptance of a new COVID-19 vaccine? Next slide, please. I'm going to be speaking to you about what we were able to find in the literature about Hispanic or Latino or Latinx, however different people use the term differently, and we refer to them as we find them in the literature. So we were asked to research what was available for that population generally, and then specifically around farm or field or meatpacking workers, and then also around Native American, Alaskan Native. Josiah will be talking about other populations later on in this presentation. Romina will. Thank you. Next slide, please. So I'm going to very briefly go through our literature review methodology and then share some of the findings with you. When that's done, and then we will also talk to you briefly about the community-based prevention marketing methods that we would like to have you engage in with us in order to develop the new materials and communication materials that we want to get out there. So I'll have the next slide, please. So the background, I'm not even going to say anything. We all know this sad set of statistics. Let's go to the next slide. Thank you. As I said, part of what we're trying to understand is our priority population. What do we already know, and what else must we learn? So part of the reason we're doing a lit review is so we don't repeat the wheel. Let's go to the next slide. And the questions that we were asking, I'm not sure why this one got messed up, is what do we already know about knowledge, perceptions, motivators, facilitators, or barriers to either COVID-19 testing or to vaccine acceptance. Next slide, please. So because COVID-19 is new, we have to look at other relevant behaviors, such as other immunizations that these populations have received. We want to be looking at recent history, so seasonal flu or perhaps hepatitis. We want to also look at historical events that might affect how the community views immunization, health care, or the U.S. government. And we also want to look at some previous communication campaigns that have possibly been better or more effective with a particular population. Next slide. So this is just to show you that we start off by looking at a lot of literature, and actually not everything is included here, because as I mentioned, the Morehouse set aren't included in what I'm showing you here. This is what we did with USF. And so we started off with 537 plus another 35 records that we worked down to, at the end, about 95 articles that were synthesized because they had useful information. All the others were reviewed, examined, extracted, so a lot of them were duplicates, or they just didn't have anything that we could use in the study. Next slide, please. So the next set of findings have to do with screening and testing. Next slide, please. I told you I go fast through these. Okay, here's the highlights. Now, you will also be provided with the actual written documents, which runs 50 pages. So I'm just giving you the absolute top line thing. And one of the things you're going to be seeing is how little has actually been published for any of these important populations when it pertains to these issues. What we did find, and when I tell you this, the way you have to interpret this information is, in the majority of studies that we read, then we will say this population, so Hispanic, Latino, Latinx, were more likely to be essential workers with limited time to devote to testing. As a result, they were less likely to be tested. They were also less likely to be able to physically distance from people outside of their household. And they were, at the time that the survey was done in May, less willing to install a tracking device for contact tracing. Some of the barriers that they had for COVID testing, there were concerns about immigration status. They wanted to minimize health system contact. They were concerned with medical racism, and there were some lack of transportation options. The facilitators would be if a healthcare provider gave them an explicit recommendation, as well as credible counseling from trusted sources and clear and readable materials. Next slide, please. One of the specialty areas had to do with those in the food processing industry. And for those we saw, they were less likely to access testing services. It was difficult for them to practice social distancing or to even wear face coverings. There was one survey that found that they had a good level of knowledge about COVID-19, but they perceived that they had lower risks. Some of the barriers included a lack of insurance, but they perceived that they have lower susceptibility to the disease. They have long and non-flexible work hours, concerns that quarantine or a positive test would prevent them from working and therefore earning their income. Some of the facilitators included access to testing services at work sites and flexible working hours. Interventions that are needed, of course, need to address not only their life at the plant, but everything about their life at home and the transportation and in their communities. Next slide, please. All right, I can just summarize this by saying for Alaska Native American Indian population, there is no published peer-reviewed research at the time on their knowledge and perception of COVID-19 testing. There's a lot of ongoing research and so we can expect there'll be some publications coming out shortly. Next slide, please. All right, now we're looking at the potential for COVID-19 vaccine acceptance in these two priority populations. Next slide, please. So we looked at the history of vaccine acceptance in these populations. And some of the things that we saw among Hispanic, Latino, Latinx is they're more likely to have some misperceptions of vaccines as curative as opposed to preventative among people that have been surveyed. And I can think of reasons for that because there's a lot of a tradition of getting immunizations or getting shots of vitamins and things like that. So for them, a shot is not necessarily only a vaccine. They're less likely to receive an influenza vaccination, and they reported less awareness of its recommendation and benefits, again, among those who have been surveyed. Some of the facilitators to getting vaccines is, again, healthcare providers providing recommendations that they've used vaccines before, that they have insurance, and that they're concerned about the perceived likelihood and severity of a future infection as well as the perceived effectiveness of the vaccine. I think this is going to apply to everybody that we're talking about. Some of their barriers, though, are feelings of discrimination, concerns of safety and side effects, lack of health insurance, general distrust in the medical care system, language barriers, and lack of culturally competent care. I guess this is no surprise to anyone that's listening to this. Next slide, please. Among our farm field meatpacking workers, these are precedents. So we're dealing with flu shots for the most part. We have a good knowledge on influenza virus modes of transmission, risks and benefits, but a little limited knowledge on prevention measures among those surveyed. Facilitators include having been infected or witnessing a diagnosed patient, having access to vaccination at work sites, provider recommendations, as well as having appropriate communications that come from a trusted source. Particularly for those who are migrating or crossing borders, transient populations, it's been recommended that we could provide seasonal influenza vaccinations at transit points, immigration facilities, transportation venues, and cross-border towns. Of course, I have no idea how that's being done these days with what's been happening politically. Barriers include fear, concerns about safety, low perceived risk of, this is from the H1N1 influenza, mistrust of government, inconsistent information, et cetera, et cetera. There's one other little note in here which has to do with fatalistic beliefs in terms of, well, if you're going to get sick, you're going to get sick. So that's something we have to keep in mind too. Next slide, please.
Claudia, and we will want to wrap this up. We can move on to Mimi's presentation as we are 2 minutes left.
Why don't we jump then, because there's nothing to say, there's been nothing published, I'm sorry. Communication campaigns, I'll let Mimi talk about that when she gets there. So let's skip through that. And let's get to just a little bit about the community-based prevention marketing. Mahmoud, are you gonna jump on here? Okay, Mahmouda, no, okay. So let me just tell you very briefly, the idea is that we really hope that some of the organizations that are watching this and participating in this today will come together with us in order to develop the so necessary new communications that are necessary with these communities. The idea with community-based prevention marketing is that it's not only developing communications, it's looking at the systems level changes and the policy level changes that are necessary in order to really bring about what we'll call more sustainable changes at the community level. COVID-19 has just sort of pulled off a great big covering that has unveiled a lot of what was wrong already, and we hope to be able to use it as an opportunity to start fixing things. Can we have the next slide, please? So what we're going to be doing is trying to develop capacity with those who participate, learning about social marketing, and the sort of steps that we use, including, you'll be hearing from Mimi in a minute, about doing our qualitative and quantitative research with you. It's bringing the research findings directly back to you so that you can help interpret that and help create the materials. I think that we can cut that there since we're so short of time. It's really basically getting the, let's say, facilitated participation of those for whom it's about to be involved and included in creating those materials that then will be part of what we do as NCRN. I'm going to leave it there. I can always answer questions during the Q&A.
Thank you so much, Claudia. So we just have one presentation left from ICF, so we'll turn it over to Dr. Mimi Muscali.
Thank you so much, Brittany. And if you don't mind, feel free to skip to slide 4. Salam alaikum, itinyan. My name is Mimi Muscali. I'm the director of the social marketing research team at ICF Next. And if you could go back just one slide, I'm going to very briefly discuss the findings from a review of communication materials from government agencies, nonprofit organizations, research organizations, and others. We found that these materials were more likely to speak to the general public as opposed to being culturally tailored. Although 30 of the 95 materials were not in English, and usually that language was in Spanish. There were 283 core messages, and most of them focused on COVID-19 testing instead of what to do if you've tested positive or are experiencing COVID-19 symptoms or the COVID-19 vaccine. Most of the messages imparted knowledge rather than address perceived self-efficacy or barriers, cues to action, perceived susceptibility, perceived benefits, and perceived severity. In other words, most of the information was factual. It didn't necessarily work towards persuading people to get a COVID-19 test or vaccine. And a minority of the materials had a call to action. And most of those materials usually directed people to a website or a hotline for information or a testing location. We recognize that a lot of these materials were developed very quickly and on the spot, so it's amazing in terms of what's already been put out there. But as you can probably see, there are a lot of opportunities for the NCRN communication program and for the NCRN partners as we move forward with our communication work. There's other formative research in the works in terms of a content analysis of news stories and in-depth interviews and focus groups. And I will go ahead and stop there and say a barakabake. Brittany, back to you.
Thank you so much, Mimi. We are at 4:02, and so I do want to be mindful of everyone's time on the webinar today, but maybe there's one or two questions that we can take from the chat since we skipped the last Q&A session. And then please do email us your questions that you may have that are outstanding. Many of you may be wondering, how do you get involved? How do you partner with us? We do have a contact us form on the website that Todd mentioned earlier today. That's www.msm.edu/NCRN. And so we welcome you to send us your inquiries around partnering so we can understand where your expertise and strengths are that align with our program objectives, and so that we can work together to disseminate the new messaging as well as the current messaging that is culturally and linguistically appropriate for our communities. Bria, would you mind reading off just one question from the Q&A?
Yeah, sure. So I'm just going to go in the order that they were received. So there was a question earlier in the chat from JG. And it reads, could you share more on the barbershop and faith-based conversations that were mentioned earlier? I think this was a question directed to 100 Black Men with Walter.
Absolutely. What would he like? He'd like to get more information or email or perhaps what we're doing across the country? Absolutely. Just have him contact me directly and I can call him offline. But we're doing this nationally, okay?
Okay, so Walter, I'll make sure that you're connected to that individual.
Thank you.
Thank you. Dr. Mack, did you have anything else that you wanted to share before we close?
No, just wanted to thank everyone, the partners. This was, I hope it was as valuable for you all as it was for me. So I want to thank our internal team. I want to thank Brittany and Bria for putting this together for us, and Dr. Montgomery Rice for her support. So just thank you all and stay in touch. I think Brittany gave you the information and you know, contact us as needed.